We're just going to record the session so that we can have it available on our YouTube channel. So 3 o'clock on the dot, so Wednesday, another FILOTIMO webinar. So nice to see so many familiar faces. Let's start with a little bit of an intro and introducing myself. I'm the founder and CEO of the Michalopoulos project. And joining me today is John Kominos, director on the project. Thanks for joining us again, John.
Hi guys, lovely to have you. I'm frantically just trying to mute some of you because we're getting some feedback on the session. So just forgive us for a second. I think that's better. I can't hear myself. Great. Awesome. Over to you, Ed. Let me get it started.
Thank you. And today we have a very interesting topic, one that's so relevant in most of our referrals and our cancer journeys. Today we're talking about lymphedema management, and we are very blessed and privileged to have our guest speaker today join us, Jennifer Blenkinsop, who will be telling us more about this topic and having a little presentation. So perhaps, Jen, if we could hand over to you for a little intro, and then we'll have a presentation from Jennifer. If anybody has any questions, please raise your hand. Alternatively, there's a text box or a chat box at the bottom. Text your thoughts in the chat box, and we'll get through them as and when we can. And alternatively, we'll have a Q&A at the end of the presentation. So thanks, Jennifer. Over to you.
Hello, everybody. Thanks for dialing in and for showing some interest in this topic. It's a topic that I'm very passionate about, but I think let me tell you a little bit about me first so that you can see where this is all coming from. I'm an occupational therapist. I've been an occupational therapist for 30 years now. Studied at Wits and then went over to the US, where I was first introduced to lymphedema. I'm actually originally specialized in hand and upper limb rehabilitation, but while I was there, swelling is a big part of hand and upper limb problems. And so while I was there, I discovered swelling, and that led to discovering lymphedema. So I left the States and then returned there to study and certify in a technique of lymphedema management. Was part of the EXCO, the founding EXCO of the South African Lymphedema Association. I've since also certified in a newer technique, which I'll discuss a little bit later, called fluoroscopy-guided lymphedema, manual lymphatic drainage. And so, yes, I'm very happy to share the information that we have about lymphedema. There's not a lot of lymphedema knowledge out there, but there's a lot that we can do. So I'm hoping that this talk is beneficial. So I'm going to go ahead and do a presentation first, and then as Evie said, as and when we'll answer questions along the way.
Thank you. Here we go.
Over there. Super. Okay, so let's just see. Sorry, I seem to, there we go. What is lymphedema? This is a tricky question. It's not as easy to answer as it might sound, but lymphedema is swelling essentially. Mostly in the arms and legs when we see it, but it can be anywhere in the body. It can be the face, the head and neck, the abdomen, anywhere, but really caused by an abnormal accumulation of lymphatic fluid. What differentiates it from other kinds of swelling, like when you sprain your ankle or you have a vascular problem, is really that the lymphatic system is damaged, which is what causes this problem. And the fluid is high protein fluid, which is a little bit different from the other kinds of swelling that we get. So it's not always easy to see or to define. It can be a combination of things, but essentially it's a high protein fluid based on a malfunction of the lymphatic system. So if we look at the lymphatic system, when we were all at school, we learned that the circulatory system here, with the red bit being the artery, the blue bit being the vein, we all learned that from the heart and lung complex, oxygenated blood full of good things comes down to your tissue, wherever, delivers it to the tissue, and that all waste products are drained then along with deoxygenated blood back to the heart and the heart-lung complex. But that's not entirely true. The red part is true. The arterial side is true. All good things and oxygenated blood come down from the heart-lung complex to the tissues where it's delivered. But then the structure of the vein is different to the structure of the artery. And so some of the things that come down in the artery cannot get into the vein again. And we have a parallel system called the lymphatic system, this green one over here, that equally drains some of the things that can't get back into the vein, and fluid end up coming along the lymphatic system instead of the vein. And so recent research is showing that a considerable amount of drainage happens lymphatically, much more than we ever thought. When we talk about lymphedema, though, lymphedema is mostly found in the superficial system. So we've got three parts to the lymphatic system. We've got the superficial system, which sits between your skin and the first layer of tissue. Then we have the deep system, which is around muscles and joints. And finally, we have the visceral system, which is around the gut. But when we talk about lymphedema in terms of cancer, by far the majority of the lymphedema is in the superficial system. So we're going to have a little look a little bit deeper now at the system. You'll see from my picture here that at the time where, oh, I can't see my cursor, there we go, where the green bits start, those are called initial lymphatics. That's where the vessels start. So the lymphatic system does not circulate, it only drains. So here we have your initial lymphatics. Oh, sorry, I keep losing my cursor. Then we go to lymph collectors, which are deeper vessels and bigger vessels. Then we get to the lymph nodes. And ultimately, it's dumped at an anastomosis into the vein just before it goes into the heart. So it does join the circulatory system, but it isn't the circulatory system. So if we go back to those little initial lymphatics, which are the start of the lymphatic vessels, they're funny little things, actually. They're blind little endings that look like that. And they're just made of one cell thick. There's nothing in it that says open, close every 10 seconds to let fluid in or not let fluid in. It's just this little single layer of cells. So what happens here is you have these little blue bits, which are like a guy rope. It's like the guy rope on a tennis net or a tent, which are joined where these cells overlap. And those are attached into the surrounding tissue. So that if you swell or if you move or if we stretch your skin, the guy rope pulls tight and it leaves an opening between two of the overlapping cells. And all of these little goodies that you can see, all these dots and lymphatic fluid then flows into the initial lymphatic. Once it's in, it starts heading towards a lymph node. But the important thing is here is that in this section, it's like a honeycomb covering the whole surface of your body. There are no valves that say you have to go left or you have to go right. They're inclined to go in a certain direction based on the anatomy, but they don't have to. There are no valves in that section. But now, because they know they've got to go to lymph nodes, they then join together and become bigger and bigger and deeper and deeper and become what's called collectors. And these collecting vessels look like this. And they've got a smooth muscle in the walls, so that what would happen is that the fluid will flow into an area. It's got a valve at the front. Every so often, there's a valve. So it fills and fills and fills and fills. And at some point, there's a reflex. And the reflex makes the muscles contract, which pushes the fluid forward and shuts the gate behind it. So in other words, by the time it goes into the collecting vessels, it's being pumped now to your lymph nodes. It's not just flowing, and it shouldn't be able to go back if the lymphatic system is normal. So from those collectors, they get deeper and deeper again and bigger and bigger. They arrive at a lymph node, which is kind of like your kidney. It's a little bit like the traffic arriving at a big interchange on the highway. Everything flows smoothly till it gets towards the interchange, and then it's got a tortuous route going in and eventually comes out. So it slows down the whole process in the lymph node. By the time it comes out, the traffic picks up again. So what happens in the lymph nodes is two things, two amazing things. The one is that it filters and it cleanses out bits and pieces that shouldn't be there, and passes on good fluid to the next lot of lymph nodes. But it's also part of the body's immune response at the lymph node. So your body has an incredible ability to identify pathogens. So if we took the case of you stubbing your toe, say, for example, there's a cell that's called a macrophage, which rushes off to the area, picks up a piece of whatever's inside that shouldn't be inside, rushes it to a lymph node, who's part of the identification process of what this pathogen is. If it knows what it is, it tells the body to send out the antibody, or it sends its own out to fight that particular pathogen. If it's never seen it before, it lets the body know to send out the generics, a whole lot of different ones. And then when one is found that fights that particular pathogen, then it makes a copy of that relationship so that next time your response to the invasion is a whole lot quicker. So this would kind of be what it would look like. This is the honeycomb, this is your skin. This is the dermis and subdermal layer. So this is the honeycomb of initial lymphatic vessels, which then drop down and become deeper and deeper, and you start to see valves in these vessels here, all at the bottom. And they cross between areas. They also go even deeper, which is where you start seeing them heading towards lymph nodes. So this is a really nice video that kind of shows you what I've just said. So there's your skin. Just under the skin, you can see that honeycomb network. And these are those little initial lymphatics. The gyro pulls tight, fluid flows in, and protein particularly just drops down towards the collecting vessels, which now start to pump because they're muscles, and you can see they're segmentally pumping. And drop down into the deeper collectors. And continue on pumping now. These little fibers are not the guy rope fibers. Those are just holding the vessel in place until ultimately it delivers it to a lymph node. So hopefully that makes clear how that little system works. Oopsie, wrong way, sorry. So how would you know if you had lymphedema, or if you think you've got lymphedema? What are the symptoms? So there's puffiness or swelling anywhere in the quarter of the body that's had surgery or radiation in the context of cancer. This is not the only kind of lymphedema we get, which I'll tell you about in a moment. But in the context of cancer, it's in that quarter. So the lymph nodes that are under your arm will drain, for example, one arm, one breast, one upper back. The lymph nodes in your groin will drain your whole leg, your bum, your lower abdomen, and your lower back. And each of those quarters has groups of lymph nodes that drain them specifically. The head and neck, the brain doesn't have lymph nodes in it, but it does have lymphatic fluid, which then drain out from the brain and are collected at the lymph nodes and lymph vessels in your neck. So sometimes edema is called pitting edema. And pitting edema is when you press your finger into the swelling and it leaves a big divot. That is called pitting edema. But now, not all lymphedema is pitting. The longer you've had lymphedema, the less it tends to pit and the more fibrous it becomes. Some people just have a sense of fullness or heaviness. That is their first sign that something's up. Some people have pins and needles or numbness in the limb. Now, this needs to be new. This needs to not be something that you had from before surgery and before your treatment. It's new, it's only on the side that you've had surgery, and it's one of the possible symptoms. You may have aching in the limb or the shoulder or the back of the shoulder if you've had lymph nodes out, or have lymphedema in the arm, or in your bum if you have lymph nodes out or lymphedema in your leg. Some people feel that their limbs are about to burst, they're tight. And sometimes people have skin changes. The skin changes in color, it changes in texture. They get little nodules on them. All sorts of things on the skin can change in the presence of lymphedema, but it is not an initial sign of lymphedema. That's usually is there because you've had lymphedema for a while. So how do we diagnose this then? Because remember that some of those things on the previous list are not things that are only found in lymphedema. You can have swelling from other reasons. You can have pins and needles from other reasons. You can have aching from other reasons. So we need to be careful when we diagnose this. So we firstly take a careful clinical history. What treatment have you had? What kind of cancer have you had? What surgery have you had? Where was it? How does it look? What are your scars like? Then we look at the swelling itself, which can take different forms, remembering that you don't, even though your nodes in one quadrant might be removed, that doesn't mean that the whole quadrant swells. It can be just a little part, like in your arm, it could just be your hand, it could just be your forearm. It's not necessarily the whole area. So we look at the swelling, we look at the texture of the swelling, the quality of it, how does it behave, what makes it worse, what makes it better. Then we have a look in the leg for something called Stemmer's sign. And Stemmer's sign is if you pinch the skin on the toes at the very base of your toe, is it all thick and sort of, thick and difficult to move versus the other side? That is a sign of that swelling's been there for a long time, even if you weren't aware of it. And then the skin changes that we talked about. So papillomata are little nodules on your skin. Hyperkeratosis, we see often with vascular problems where people have got a sort of a browny redness on their shin. Lymphoria is when you start to leak lymphatic fluid, and that's just like a little drop, like a little sweat droplet, just leaks from somewhere, and you can't always see where somewhere is. And then if the lymphedema is bad enough, you do get skin folds. But diagnostically, from a medical point of view, usually we can know already from the clinical picture. But if we're not sure what kind of swelling this is, we can look at something called Lymphocentigraphy, which is a scan that you get at nuclear medicine, where they put a dye between your fingers or your toes, and then they scan you over a couple of hours. And they can see, basically, does the lymph stop? Is it slower in one area than in another area? Does it pool somewhere? The downside of it is it's not in real time. You're seeing it a few hours later, and it does very much depend on the technician and the position that you're in. So while it's extremely helpful and was the gold standard for a very long time, we do have a couple of other exciting options now. The other one I'll show you a picture of in a moment is called near-infrared fluorescent imaging. And that's one of the most recent advances and exciting advances in lymphedema. And that's where we put a near fluorescent dye in and then turn the lights down and put a near infrared camera on. And we can see your lymphatics working in real time while it's happening. We can see them pumping. We can see where they're going backwards instead of forwards. We can see where it stops. We can see where areas where it drops down. So that's a very exciting advancement. And we can map where your lymphatics go, basically. And that's terribly important when it comes to surgery, but certainly when it comes to lymphedema, it's helpful. It's not critical, but it's certainly helpful when we're managing the situation. Other tests like MRI and CT are not really that useful. They're more useful than nothing, but the lymphoscintigraphy and the near infrared fluorescent imaging is better, or fluoroscopy guided imagery. Dopplers are done when we're looking for DVTs, and certainly some of the cancer medications do predispose one or increase the risk of a DVT, so Dopplers are important. And for general ultrasound, we also use that. It shows, particularly in breast lymphedema, it shows skin thickening. There's a kind of lymphedema you get from a mosquito, and we test for that with ultrasound as well. This is a picture of what we can see when we do the near infrared fluorescent imaging or fluoroscopy guided imaging, and it's fantastic pictures that we get to see. And each kind of pattern that is formed demonstrates a different thing that's going on with lymphatic collectors or with the initial lymphatics or with different parts of the system. It's really super. In terms of the types of lymphedema, there are two different types. The one is called primary, and those are ones that you're born with or you have a genetic predisposition to. Might not present immediately when you're born, it might present later, but nonetheless, it is a problem that is there from birth. The secondary type is the one we're going to focus on because it's the one that cancers are involved in, and that's where we have an external cause for that lymphedema. Something happened to a normal lymphatic system to cause this. So it could be malignancy itself. There are a couple of malignancies that happen in the lymphatic system. It could be what medical term is called iatrogenic, which means we caused it. Us medical people are the reason it happened, and that can be from removal of lymph nodes, from surgery, from radiation. It can be factitious, which is a mental health problem where people self-mutilate. It can be from trauma, where burns or crush injuries involve an entire circumference of an arm or a leg or an area, and then your lymphatics can't get past that. Filariasis is the most common form worldwide, and that's very interesting because it's a parasite transmitted by mosquitoes, and it is found around the equatorial band of the world. We will only have it from travelers here in South Africa, but it's a very significant number of people in the world have got filarial lymphedema. And then phlebolymphedema is where you get swelling that is persistent from vascular problems and circulatory problems, which start as vascular problems but become lymphedema over time. These are just some pictures. So you can get very severe lymphedema, and certainly the leg on the right-hand side is severe, but it can be worse than that. But you don't always have to have significant lymphedema. It can be quite mild, or it can be just the foot or just the hand or just the top of the arm. It's very varied. And I would caution people who may think that they have lymphedema not to go onto the internet and look for the most atrocious pictures that are out there. If you get management and good treatment, it's not going to look like that. If people are looking to be online and have a look what's out there, just go onto the national lymphedema sites for different countries. Don't go and look for the blogs and things up front, because the kinds of pictures that people post are very concerning sometimes and may never be you. So in terms of the stages of lymphedema, lymphedema starts in what we call the latent stage, where you can be accumulating fluid or struggling to drain, but there's no clinical signs of swelling and you can't feel it, or sometimes you're starting to feel it, but we can't see it. Stage 1 is where it's pitting. Remember, that's where you put your finger into the swelling and there's a divot. But if you go to sleep or you lift your legs or raise your elbow, your arm, the swelling goes down. That's stage 1. Stage 2 is when it's maybe superficially pitting, but if you go to bed or lift or elevate, it doesn't actually go down completely anymore. It might do some, but not completely. And then stage 3 is when we get those big skin changes. There's no longer pitting, it's thick and fibrous tissue, and it's kind of like the leg on the right that you saw. So what do we do about it? So the first thing to know, and this is the difficulty of lymphedema, is that we can't cure lymphedema at this point. There are some surgical procedures that are starting to explore that possibility, but at this point we can't cure it. It is management, it's long-term management. So once you have lymphedema, the best thing to do is to catch it early so that we can keep the size and form and shape of your limb as it was going forward, but you will always need to be managing it. And without question, the hardest and the most important part of treatment for lymphedema is compression. The other aspects include exercise, very importantly, skin care, and manual lymphatic drainage. So why and how does compression work? It's a mistake to think that compression just squashes fluid out, because it doesn't just squash the swelling out. Remember that picture I showed you in the beginning, when the artery brings down all that good stuff down to your tissues? The artery does not know how much blood and nutrients to deliver to your tissue. It doesn't know that you need 1 piece of protein and 2 pieces of potassium. How it determines how much blood to give and how much fluid to offload is by the pressure gradient in your tissue. So the arterial pressure is normally high and the tissue pressure is normally lower. So if the artery is high and the tissue is lower or very low, then a lot of fluid is dropped off. If the arterial pressure is high and the tissue pressure is quite high, then just that relative difference is dropped off, not as much. So what happens when we're doing compression is we are increasing the tissue pressure so that the difference between the arterial pressure and the tissue pressure is much less, so less fluid is dropped off. So yes, you do get, when you first put compression on, you do get some pushing of that fluid back into the vessels, but essentially it's more about reducing the amount of fluid that's dropped off, not squashing fluid back. It also pushes the fluid into areas that can drain well and therefore drain that swelling out. Where people have got very thick and dense tissue, the compression also helps to soften that fibrous tissue and make the skin a whole lot more like the skin elsewhere in your body. And so when we do compression, what we're looking for is we want to reduce the size of the limb. We want to improve the skin condition. We want to improve the consistency of the skin so it's not stuck and thick. We'd like the limb shape and function to improve. We'd like to improve the control of symptoms. Sometimes people have pain, sometimes people have pins and needles, sometimes people have difficulty moving. And if our compression can bring the swelling down, often that can resolve those problems. And obviously, sometimes there's a real problem when people are bedbound and carers are needing to be assisting, that if the leg or the limb size can be reduced, oftentimes it makes the life of the carer and the patient a whole lot easier. So these are the kinds of compression we look at. When you have a big limb or a swollen limb, sometimes your doctor might say, oh, just go and get a stocking or just go and get a sleeve. And the problem with that is that the sleeve is a certain size. It's like going to buy shoes. That is the size that the shoe is, or that is the size that the sleeve is. Now, let's say we put the sleeve on and your arm goes down a bit. Well, now the sleeve's actually too big and you've just spent $1,500 or $2,000 on a sleeve. And actually it's now not the right compression for you. So where there's a good few centimeters difference in girth between your affected side and not, it's better to bandage first. We bandage and we rebandage every day, so that every time we bandaging, we're bringing down the size of your limb. And we do that each day so that we can accommodate for changes. And then when your limb gets to the size where it's not improving anymore, or it's the same as the other, that's the time to get the correct size sleeve or stocking, and you get it once off, and then we're done. So the important thing is this is not just crepe bandages off Disc-Hem's shelf. It's a very special bandage used for lymphedema called short stretch bandaging. We do them in multiple layers, and we create a gradient where the compression at the bottom needs to be a little bit more than the compression at the top of your arm, so the fluid goes up, not down. It's not very tight. It's a misnomer to think that the tighter you pull this bandage, the better. You can give yourself more problems pulling tighter, which is why it's terribly important to have a lymphedema therapist show you your bandaging and teach you how to do it versus getting it from YouTube. The bandages are worn continually because if you remember now that the amount of fluid in your tissue is related to your artery bringing fluid down to your tissues, if that's the case, this is happening every minute of the day. So you are getting circulation every minute of the day, which means that if you take your bandage off, you're going to start swelling because your artery is still delivering fluid, even though without your compression on it will allow that fluid to accumulate and not drain out. Whereas with compression, the artery is still bringing fluid down, but it is compressed and therefore doesn't allow your fluid to accumulate. This is a different system of bandaging, which has like a padding with little blockies in it. Very, very effective, particularly where there's fibrous, thick fibrous skin. And it's an easier bandaging system in terms of putting it on, but it is a lot more bulky than the previous one. So your therapist would advise based on your condition, how easy it is for you to reach and what your needs are, which bandaging system would be better for you. And then we have the compressor and hosiery, which is the sleeves and the gloves. And they're all sorts of different designs and styles of doing them to assist you, depending on the size, the shape of your limb. Unfortunately, some people need custom-made gloves and sleeves because their arm shape is not absolutely standard. But if you can fit in one that's out of the box, it's obviously much cheaper. And so these are some for legs, but I put this slide in because not all the designs that are out there do what you think they're going to do. So this person has bilateral lymphedema, which is why she's got a stocking on each leg. And what the picture shows on the right is what the box shows. What the picture shows on the left is how the stocking actually sits. It creeps down as you're wearing it. So one has to be very careful with what kind of stocking and what kind of garment you have. There are garments which has a short leg and a long leg so that it stays up all the time. They're pantyhose. But in general, these ones with the thing around the waist, they don't stay up very well. And so you really need to be well advised as to what kind of stocking you might get. You get different kinds. You get flat knits, you get round knits, knee highs, pantyhose, all sorts. But if you're in the care of a good therapist or orthotist who's going to measure and supply the stocking, you should get the right thing. And this is just to show you that there's some quite cool things happening out there. There's a brand called Juzo that has all sorts of colors. This comes from a site called Lymph Divas. which has tattoo designs and designs more for men, designs more for ladies. In the world of these sleeves, there are a couple of brands that are very well known for being extremely high quality for lymphedema. Not cosmetics was not their thing, but lymphedema is their thing. So I would suggest that although these are class 2 sleeves, all of them from Lymph Divas and from other companies, the compression, even though they look cool, is not always as good as the original one. So it depends on your arm, and it depends on how it's all behaving. And then, because it doesn't go down at night, if you're in, say, for example, stage 2, because remember, stage 1 goes down at night, so you don't need compression at night for stage 1. But stage 2 doesn't go down at night, which would mean you'd wear your sleeve the day, swelling would go down, and you take it off at night, it will go up at night. So there are different kinds of night compression garments that you can wear, or you can bandage, depends on the budget more than anything else. So this is one. These are 2 other kinds that we can get. That the one on the right, the auto fit, is adjustable, which is quite nice. The other 2 aren't adjustable. But again, you don't get these up front. You get them when your arm is under control. So we get the right size up front. Then in terms of exercise, people always ask with exercise and lymphedema. And unfortunately, lymphedema is not one of these things where you have a recipe book. It's going to depend on what your body is doing. And so you will need to observe what your body is doing. But there are a few things that are important to know. There are exercises specific to lymphedema, but in general, despite those exercises, exercise and lightweight training is protective against lymphedema. A long time ago, we used to say that you can't exercise and you can't exercise with more than a couple of kilos, but we know that not to be true now. It's more about not doing sudden changes that traumatize tissue. But if you slowly but surely increase your exercise program, adding one thing at a time, slowly upgrading the program, then exercise is often protective against lymphedema. But you will need to find your own level. You'll need to watch your own legs and arms and see what happens and what your level of tolerance is. And don't try and push it. Rather stay at that level for a whole long time and then just creep up and just try a little bit more. But if your body says that a certain limit is a limit, then do listen to that, because otherwise your lymphedema is not going to be helped, it's going to be harmed. So we know that exercise increases your lymphatic pulse rate up to 6 to 10 times. Now the picture on the right just shows what happens when your muscle contracts. It squashes around a lymphatic vessel and helps that pumping. So it's pumping already, and then you enhance the pumping by the muscle contraction, and even more so if you have compression on. This is one of my clients here who's a cyclist, cycling away with his sleeve, his compression stocking, sorry. So the take-home message on these things is that lymphedema should not dominate your life and take your life away. It's more a matter of how can we manage your lymphedema so that you can do life and so that you can do the things that you enjoy. Okay, I think we covered this on the previous slide. And then in manual lymphatic drainage. Manual lymphatic drainage is probably, if you have a limitation to your funds, limitation to time, this is the one part that we could probably leave out. I know that us therapists might be horrified at the thought, but compression is the single most important thing. Managing your skincare, managing your own exercise and diet and things like that. Those are the things that are the most important that you can do. But if you have access to a lymphedema therapist, it certainly is a very good adjunct and will certainly be helpful. And what it does is the lymphatic drainage is exceptionally gentle. Because if you remember the picture that I showed you in the beginning of the initial lymphatics and the dermis, and that those little anchor filaments or guy ropes are attached into the surrounding tissue. And all we need to do is to pull the surrounding tissue to open the vessel to let fluid flow in. And remembering that those are just in the dermis, if you squash hard on it, it's like putting your foot on the hose. Nothing's going anywhere. So what you want to do is you want a gentle stretching on the skin, pulls the guy ropes open, allows the fluid in, and then directs it in the area that it should go. And so what happens there is it just picks up the extra protein and extra fluid, directs it away from where it's congested into uncongested areas, to functional lymph nodes, it increases the rate of flow. And always you work trunk first and then further away. And that's just the idea there is it's a bit like a traffic jam. The guy at the front doesn't move, the guy at the back's never going to move. And because your lymphatic system isn't circulating all the time, you start under the arm or at the groin, and then you move down towards the hand or to the foot. But your therapist would show you that and show you a self-massage program that you can do, going forward at home. Skincare is critically important because of the lymph nodes' role in immunity, which I told you about earlier. If you have your lymph nodes out, the challenge there is that your little macrophage that we said picks up a piece of pathogen or something, rushes it to a lymph node. If it can't find the lymph node or there are too few and it takes forever to get there, it's not that you can't fight, it's that your response time to the invasion was too long. And so it's critically important that you minimize your risk, first of all, of getting cuts and grazes and things. But where it's not possible to minimize that risk, what just happens is to aggressively treat any cuts and abrasions in your skin or fungal infections between your toes. Soap and water first, or an alcohol swab if you're out. If that starts to look a little bit dodgy and worse than it would if you were somewhere else in your body, then you're going to try and put a Bactroban or a Supraban or an antibiotic ointment on. And if that's still not working and it's still looking angry and dodgy and you're starting not to feel well, go immediately to the doctor. If you get an infection and you have lymphedema, it tends to make it worse and it's difficult to get it back from there. So we're almost at the end. So in terms of reducing your risk, in terms of breast cancer, only about 30% of people get lymphedema who've had their lymph nodes out and have had radiation. So that means 70% of people do not. And that's really important to remember. If you've only had a lymph node out, a sentinel lymph node biopsy, your risk is much less, between 6 and 10%. However, it can still happen. And so what you want to do is, if you've had surgery to your lymph nodes, is just be aware of certain risk-reducing factors. It's not the make or break, but these things can minimize your risk. So the key and most important one is not to let anybody take blood pressures, injections, bloods, anything on the arm or the leg that has got lymphedema, unless it's absolutely necessary and there's nothing else that can be done. Remember that you're the person who lives with lymphedema if you get it. And that's not only for people who've got lymphedema, it's for people at risk. And the person who's at the laboratory does not live with lymphedema if you get it. So be assertive about that. Take precautions to avoid trauma to your limbs. Use mozzie sprays, wash dishes with gloves, avoid scratches, use sunburn cream, etc. Just do what you can do without obsessing about it, though. Not lifting suddenly heavy things or doing sudden strenuous activity. It doesn't mean you can never do it, but it's that thing with the exercise again. If you slowly upgrade and slowly increase your tolerance, then heavy is not so heavy. But if you go from doing nothing to doing heavy stuff, that's quite traumatic to your body and can result in a swelling response, which doesn't go away. You want to avoid wearing tight things and tight clothing that obstruct the lymphatics. Keep cool on every level. But one of the things there is that it's not so easy when you live in Durban, and it's not so easy if you live in Mozambique. But where you can, do try and keep cool, because it's unquestionably a difference when it's hot versus when it's cool. So most clients do better in winter than they do in summer anyway, but do what you can. We talked about skincare already. Keeping your weight well controlled. Without question, if you're carrying extra weight, you will carry extra lymphedema. And if you lose the extra weight, you will lose the extra lymphedema. It's not a cure. It's just saying that you will have less if your weight is well managed. And if you have not got lymphedema, but you have had lymph nodes removed, it's wise, if you're doing long haul flights, to consider compression just for the flight. There are a few times when we won't do lymphedema treatment, when there's active infection, when there's severe inflammation, if people have DVTs, if you've got cardiac or pulmonary disease or renal failure. Those are all contraindications to doing manual lymphatic drainage massage. but they are not contraindications to compression. But you would not just put your stocking on. You will most likely not tolerate your stocking if you have an infection or inflammation. So you'd need to contact your therapist to see what's the best kind of compression to use if things are not working out so well. And certainly if you have severe arterial disease, you're not going to be able to wear compression at all because it'll stop your blood flow. And so people always ask me, aren't there surgical options? Isn't there a cure? So there are some surgical options. But unfortunately, we have nothing that's a cure at this point. We have lymphatic bypass grafting that's showing promise. Lymphovenous anastomosis is where you put a lymphatic vessel into a vein. That's helpful in the early stages, but the jury is out on the long term and as to which patients are going to benefit. The lymph node transfer was a very exciting development where we take lymph nodes that are working from somewhere and just pluck them basically in the area that's swollen. But mostly some were cured from lymphedema. Most only improved somewhat. So that still means you have to wear your compression and do all of that. You're just a little bit better and your shape is better. And some people had no improvement at all. The upper limb results were better than the lower in research, but we just don't have enough data long-term to know the long-term outcome. Liposuction is sometimes used. It's a very specific kind of liposuction. Again, occasionally some people will benefit more than other people, but it's mostly for those where the lymphedema is accompanied by a high fat laydown, which is a particular kind of lymphedema. It's not for everybody. So what I would suggest if you're thinking of surgery is ask your therapists. They're very good therapists in South Africa. They can give you some information. They can give you information about the research that's out there. Please don't Google somebody online and just go and have yourself a procedure. Nothing that we know of out there is absolutely perfect yet. All of them have specific clients that they're better for and specific that they're not. And therefore, if you're considering surgery, you need to be very, very cautious as to what type you're looking at and also what the risk to benefit is. And most of them at this stage are still requiring that you wear your compression. So lastly, we have an association called the Lymphedema Association of South Africa that has on it all the therapists who are certified in the various techniques of lymph treatment. It has something about anatomy and physiology and stuff on there as well. So please feel free to visit that site and see if you need help, if there's a therapist near you, and you can see who's out there. And that's my story.
Wow, sure. Very, very informative, Jenny. And we've Jennifer, sorry, and we've had some questions that have come through. And let's start, John, with the first one, which was a DVT question.
The query there was, you mentioned DVT, was that deep vein thrombosis there, Jen?
Yes, sorry, that was deep vein thrombosis.
Okay.
We see that in some of the post-breast cancer medications and the other chemotherapies do increase one's risk of a DVT. And so one just has to be very aware when you see swelling, particularly of sudden onset, that you evaluate it cautiously. Yeah.
Great. Then second question came through. What would you say is the best exercise for lymphedema in the lower leg and foot? The viewer has bandages and a few class 2 compression stockings and says it's a bit cold for swimming now.
Well, for some of us, it's always too cold to swim. But yes, so the calf pump is your single biggest ally in lower limb lymphedema. So toe raises, ankle circles, ankle raises, things like that are going to be a very good friend to you. Anything that works hard on the calf pump, with or without extra weight, to do that. Walking is good, but you do have to watch what your leg does, and as is cycling, and on a stationary bike or not. All of these really you want to do with your compression on to add to the benefit of the exercise.
Then, Jen, in terms of product, what in your opinion is the best leg compression stocking? The viewer has used, it looks like Jobst, Sigvaris, Mediven. Can you recommend any of those or an alternative?
Well, the first thing is the best compression stocking is the one that fits you properly. and different brands have got slightly different variations on them. So the tricky thing comes in is, first of all, shape and size and length. Not all of them are exactly the same. The compression class should be the same. And Juzo, Sigvaris, and Mediven are very, very well-known international brands. Certainly, I personally like the Mediven the most, if I can choose, and if it fits. And the reason for that is their sizing, they have multiple sizes, and the sizing are very close to each other. So if you have slight changes or slight difference, if you've got 7 sizes to choose from, the chance of you getting exactly the right size is greater than if you have small, medium, and large. So it accommodates for much smaller differences. And Mediven is very good at that. Jobst also is not too bad with that. In terms of custom garments, either Mediven or Jobst are both very good. Tuan has a more reasonably priced custom garment, which is very nice as well, and comes in not far off the cost of a normal out of the box. That's for a round knit. When you're looking at flat knits, they're obviously more expensive, but a flat knit out of the box has to fit you perfectly. Otherwise, it's a waste of money. Rather go for a round knit. But if you're going to get a custom one, a flat knit material is cooler. It's thicker, which does sound counterintuitive. It's thicker, but it is cooler. And it offers better compression. It depends on how bad the swelling is and what kind of swelling you've got.
Thanks, Jen. Another question from June. June asks whether you offer any treatment other than what certified lymph physio practitioner Brioni Kirkler offers. I think I've spelled that correctly.
So that's an unfair question. But what I can say is I offer the whole range of lymphedema treatments that is typical. I've qualified obviously in the fluoroscopy guided and the other, the normal to more traditional treatments. So each therapist, you must know, therapists first get their training and then they devise things that they learn over time have worked for them. So they'll develop a preference for a particular bandage or a preference for a particular kind of compression based on their experience with it and in their own hands. So therapists might offer some different things. There are bits and pieces out there that are complementary, things like the rebounder, things like there's certain vibration things and lymph touch and the various bits and pieces that fall a little bit outside of the gamut of everyday treatment. That doesn't mean they don't work. That just means that they're not in the traditional grouping. So you might find therapists that have a preference for those aspects. Yeah, I think that's all I can say on that.
I hope that answers your question, June. Another question comes through from someone who will be having some lymph nodes removed with her breast surgery. The question is, is there anything one can do before surgery to prevent lymphedema?
No, not really. The key is probably to see somebody, I'm not sure where the person is from, but to see somebody very, very soon after, the day after, 2 days after surgery, to give you an exercise program that is appropriate to the surgery that you've had. Because the idea that the quicker you get better and if you can quickly get all your motion back and be heroic, that's not a great idea when it comes to lymphedema or something called cording or axillary web syndrome, which is something that can happen after your lymph surgery, where that becomes particularly painful to move your arm. And we think it's a thrombosed lymphatic vessel. But the issue is not the lymphatic. It does tend to put you at a higher risk of getting lymphedema if you get this, but it's just jolly painful. And then you can't move your shoulder and then you'll end up with a stiff shoulder and all sorts of other complications. So depending on the doctors you're working with and where you are, it's most ideal to see a therapist very shortly after surgery, who is well-versed in breast surgery or the surgery that you're having, and that they can assist you in an appropriate program to limit your risk.
Steve, I think you've got a question.
Yeah, I'm just dying to tell you that Jen was my therapist. Hello, Jen.
Hello, Steve.
And she came to me when I was in Morningside Clinic just before surgery and introduced herself. And she also gave me a little exercise book, and I still do those exercises every night. And
Impressed.
I credit that with my speedy recovery, which really it was very quick. But there was that incident of the cording. And I don't know if it's in the veins or the nerves or what it is, but they kind of get hard. And Jen was able to loosen them with a massage. It was very painful, but very effective. And then after that, I was fine. But then I had the treatment for the lymphedema. I wore compression for about a year. But now it's stable. So it's not getting any worse. It's not getting better, but it's not getting worse. And it's very mild.
That's great to hear. Thank you, Steve.
And just one thing, we have had a few queries from other champions. I know Babette was one, asking about exercises post-surgery. So I think I know that Jen has books on the subject, but it's her property, so they should ask her for an exercise program.
So thank you, Steve. So the tricky thing is that the way that we work is that the doctors are the head of the medical team. And so it depends a little bit in the group that you work in and where the therapists are and which doctors they're working with, as to how much they permit therapists to come in and do the exercises post-op. So in our group, we have an excellent team that works together, and we've devised the books together. And so everybody's on the same page. We understand the surgery the doctor's doing, the doctor understands what we're doing. So it's a really ideal environment. But not everybody living everywhere in the country has access to that. So that becomes a little bit more tricky. But ideally, yes, you do want well-constructed exercises programs after surgery if you can.
Thanks, Jen. Nicole, did you have a question?
Yeah, I just wanted to say, I think it's just so important, the awareness for people before they're having surgery to be aware of cording and lymphedema, just from my own experience. I mean, I had brilliant surgeons and I was never really even informed before about, lymphedema. And I actually did develop cording, which I didn't even know was cording. Only when I studied my navigation, I mean, luckily I went away, but I mean, it went away by itself. But I mean, I was very active, I come from a running background, so I started exercising very soon after my surgery with the blessings from my doctors and my surgeons, and my cording went away. But I think it's so imperative that patients are made aware of, awareness of the lymphedema and the cording. And I think also, like you mentioned, that a lot of the surgeons have very different attitudes towards exercise and how soon afterwards you should exercise. And I think, again, like you say, it's very much going towards the individual person, how active they were before. There's all of those conditions, but I think there's definitely a place for more awareness. Like Raquel says, before surgery, to be aware of all of these things so that you can take action quickly if needed.
Yeah, I think I agree with that. I think the more you can have information, the better. There's always a balance because there's so much anxiety going into surgery as well. So overwhelming people with every possible something that could happen is also a little bit tricky. But at the same time, that has to be balanced with the more you know. If you're that kind of person, the more you're going to manage it better. But for some people that is an additional stress and in a super anxious situation already. So yeah, one has to balance out that.
Anybody else have a question for Jennifer?
Yeah, can I say something? I've had 2 breast cancer operations, first on my left side and then on my right side. I got some lymphedema from the first operation because I had 2 operations within 2 years on the left side because it's a whole long story, and it definitely swelled up my arm. And then in 2019, I got breast cancer on the right side, and I had a chemo for both of them and radiation. And last year, or 2020, yes, I had about 4 or 5 weeks of radiation. And that first month in lockdown, by the end of April, May, my arm where the lymphedema was terribly swollen. I don't know why it suddenly got more swollen than ever. But as I say, I go to Bryony Crickler, and I had to bandage up for at least about 2 weeks. And every week I have to bandage up just to keep it down. But it's such a pain. I mean, especially around the hand, it gets dirty, you can't bath properly. Oh, it's an absolute nightmare. If we're ever washing these long bandages and all the things, I'm sure Jennifer knows what I'm talking about. Oh, it's an absolute pain.
So I have to say that we can feel your pain, those of us who have done the courses, because we have to wear them during the course too. So we understand that you can't butter your toast and you can't do a lot of things. So we're aware of the difficulties. It's really just doing our best to mitigate against those.
It's so hot in South Africa. I'm sure if I lived like in England, it wouldn't be a problem, but here it's boiling hot.
Yeah,
that's why it was me asking whether you do anything different to Bryan, because I also feel desperate sometimes. And now the aid are giving me a problem, Discovery, and they said, now I've had 57 treatments and nothing's got better, so we're not prepared to fund it from your oncology fund anymore. So I don't know what. But
are you wearing your compression constantly?
Yes, I've got that night one as well. Yes, all the time.
As well. Yeah.
I don't know. It's just such a nightmare, this whole thing. It's so hot. I want to die, you know. I can't. I've had to give some of my clothes away. I can't get my arm into some of my blouses. I've been buying men's large, so especially last year when I had the bandage on. I can't wear half my tops. It's a nightmare. Actually, sometimes I feel quite low about it. You sort of feel depressed, you know. Doesn't do one's self-image any good.
No, and June, I think that all of those things are super important that you've mentioned, and probably underappreciated in how we manage things is the personal impact. So many people, when they first hear they've got lymphedema, are devastated because you've gone through the hard stuff. You've gone through the diagnosis, you've gone through the radiation, you've gone through the chemo, and now we give you something that's forever. And it's you know, it's absolutely is unfair, and it's awful. There's no other way to describe it. It's a very, very difficult thing. However, you can live with lymphedema in such a way that your life is still meaningful and purposeful, and you can do the things that are important to you. Given that we have to manage the lymphedema, it shouldn't be a situation where you have to stop doing the things that you love.
Luckily, mine's not painful at all. I don't have any pain, and my skin doesn't dimple; it just swells. You know. Besides the fact that your breasts are just about destroyed as well, I've got the flat with the tissue from the back, and I've got a little implant here and a full implant which is like encapsulated this side. Oh God, it's an absolute nightmare. Look at the whole mess, everything, you know. But anyway, I'm still alive, so what can I do? I've got to accept it and move on. I know that. I mean, just it gets so hot, and I just think I can't bear this any longer. It's so blooming boiling, you know.
Yeah. So some people will spritz them. They'll spritz the arm with the sleeve on, because evaporation is cooling. But more than that, it's very difficult. There's just one thing I wanted to mention quickly before we finish, and that is that before we used to see only sort of legs and arms with lymphedema because they used to do mastectomies only. Now we do breast conserving surgery, and then we radiate the breast. And so oftentimes we're seeing breast lymphedema, not just arm lymphedema. And you know you've got that when after radiation, and it's not, I just want to say it's also not as life shifting and life changing as having it in your arm and your leg and wearing compression in general. But it becomes very tender and painful to lie on that side. And oftentimes that's the indication that you've got some fluid that's built up in your breast. And the lymphedema therapist can treat that. You don't have to, in general, you do not have to live with that pain. So if you get to treatment, we can manage that. We can show you how to manage it at home with various techniques if you are struggling with breast edema.
Thanks, Jen.
People always can't believe there's no cure. They say, but surely there must be something. I can't believe there's nothing you can do. Go and see somebody else. I get that all the time and trying to explain to people what lymphedema is. I want to say, well, actually, my husband beat me up. That's why I've got a broken arm. You know, I've got bandages on. It's a nightmare. Nobody knows what you're talking about. You know, I say a damaged lymph system. They look at you as if you're crazy. You know, if I battle to explain it.
Coming up to 4 o'clock, I think we've got one more question. Bobby, did you have a question for us?
Sorry, yes, I did. I also have lymphedema. I didn't even know the first thing about it when I had my mastectomy, and you know, just happened afterwards. But when I went for radiation, where they drain it, it was like she was tickling my arm, and I said to her, you know, this is useless. You're wasting time here. But she said, you can't go deep. Now, I have a little pump machine that I put my arm into, and it's in the evening. But I don't sleep with anything on because it would drive me insane. It suffocates me almost, having my arm in all that bandage stuff. So mine must do what it must do, but I put it in the pump and for an hour in the evening and hope for the best, as it were. But Steve mentioned that you've got books on exercises. We really need to get something like that out to the public in general.
Yeah, thanks, Bobby, for that. Again, it's the tricky thing is that it depends very much on the surgery and the surgeon as to how much they are freeing you to do. And so while generic information is helpful, it might not do the trick for some people. It might be contraindicated for other people. And that's where it becomes a little bit tricky.
Okay, yeah, I'm with you. Thank you.
But thanks for the input.
So we can see a very interesting topic, Jen, and I think we're going to have another webinar again to obviously try and create a lot more awareness. And of course, with so many cases that we are seeing on a day-to-day of younger ladies and men developing breast cancer, I think it's so imperative and important that we get the message out about knowing about lymphedema and the preventative measures before an operation, like Raquel has said and Nicole mentioned earlier. So definitely a very interesting topic. We've learned so much today, and I hope that everybody watching and listening that has been able to take some information back home with them. And please feel free to contact Jennifer directly. Jennifer, if you wouldn't mind just sharing your contact number and or email address. I will also share the information with the YouTube channel that we will load later on to our YouTube channel for those who want to view it later, or share the link later. But just for now, Jen, just your contact details.
So my telephone number is, I operate my practice from the cell phone, but I would ask anybody who'd like to contact me, please to do it by phone or by SMS, not to do WhatsApp. My number is 082-828-7024. That's 082-828-7024. And my email address is Jennifer Blenkinsop. That's JENNIFERBLENKINSOP
And Jennifer, you're practicing from Sandton Sportsmed in Morningside and Sandton Mediclinic, is that correct?
Yeah, I've got offices at both.
Okay, that's perfect. Thank you. I will share the information again, and anybody that has questions, please feel free to email Jennifer directly, or you can email them through to the project, evy@filotimo.org.za, and I'll ensure that Jen gets those questions and replies back to you. But once again, a huge thank you from our side. Jennifer, it was so lovely to have you as our guest today. Next week, we are going to be celebrating Skin Cancer Awareness Month. May is Skin Cancer Awareness. We are going to be sharing that information with our webinars on a weekly basis. And also like to shout out to our sponsors for today. This webinar was proudly sponsored by our partners from BMW Bryanston. Closing off, John, from your side.
Thank you, Jen. Very informative. And guys, just to remind you, 29th of May, the Hero's Journey continues, our second ultra marathon of honor. For those of you that want to be a part of this amazing event, please contact Evie. You've got her number, you've got her details. Jen, thanks very much. Been a pleasure seeing you, and all our cancer champions. Thank you very much.
Thanks for joining.
Thanks, everyone. Thanks for listening.
Thank you so much. Be safe.
Bye.
Bye.
Bye.